Hello, everyone. Okay, we're getting right to it because we have limited time. So first off, with our three expert panelists, one of the entry points is the question, can you describe / define the therapeutic modality in which you work? And within that 3-minute band, give a little information on why you chose that, if you wish, for the treatment of PDs. And so, Ashlisha, I don't care who we start with. So should I call out who? Yes? Okay, Robert, go for it. Robert works within Schema Therapy. That's your main modality, but I'm going to let you each identify your modality.
Thanks, Rebbie. Yeah, so I work these days mainly with Schema Therapy, and probably the best way to think about Schema Therapy, and in particular, we're here to talk about BPD. It's a model that conceptualizes BPD as you need to know two concepts. You need to understand what schemas are, and you need to understand what schema modes are, right? Schema modes or parts. Schemas are sort of like emotional wounds. Okay, there's this kind of emotional wounds that we carry from our childhood, and usually these are developed through unmet needs. Okay, usually in childhood, and so we carry these emotional wounds, but these are expressed through a concept that we call schema modes, all right, or parts. So if a wound like a schema is activated, and this is expressed as a part. So for example, in our model, often folks might get triggered with feelings of abandonment, okay, and that would trigger something we call like a vulnerable child mode, like a part of us that carries a wound, like a child that feels abandoned, that feels alone, that might feel desperate and that kind of thing. Okay, so these are the two concepts you have to understand. Okay, the wound itself, but also the part that expresses this. Okay, so it's a parts model. Now, the other modes we call parts that are very important to understand, firstly, are the inner critic modes. All right, so these also tend to contribute towards personality disorder and BPD. So most folks with a BPD diagnosis would tend to associate themselves with having an inner critic type of mode or part. That's also worthy of treatment. And another set of modes we call coping modes. So these are parts that are to do with survival. One of the most common coping modes in BPD is something we call a detached protector mode. All right, so we tend to see folks with BPD have a capacity to shut down their emotions and cope by often through things like going numb or a more dissociative type of symptoms. So in Schema Therapy, we have 4 intervention categories that we like to focus on. It is built upon CBT, so the sort of legacy techniques are cognitive and behavioral techniques, okay, in Schema. But to these 2 categories, we also add some potentially powerful ingredients, all right, and that is a therapy relationship that we call a limited reparenting therapy relationship, right, where we want to use the therapy relationship as a vehicle for change to meet some of the unmet needs for some of these folks, experiences unmet growing up. And we want to give them a taste of something that they might have missed out on growing up. All right, using the therapy relationship as a sort of N=1 vehicle for change. And we hope then that folks might be able to generalize their experience, more positive experiences within the therapy room to their outside relationships. So that's a big part of the model, is that therapy relationship. The other one that's a bit more novel in regards to CBT is what we call experiential techniques. All right, so we have this kind of idea in Schema, based also on the neuroscience, that to heal schemas, you have to feel it to heal it. All right, so we have a set of techniques. Some of them are sort of trauma-based techniques. One of them that's quite popularized is we call imagery rescripting, which has its own evidence base in trauma. But also another one you might have heard of are chair work dialogues. So we like to engage with parts in ways such as working with an inner critic on a chair and things like this. So these are the 4 intervention points. And the overarching idea of healing with folks with BPD is to try and give them an experience of met needs. Okay, we want to help folks either connect or reconnect with their core emotional needs that might have been unmet largely growing up. There's your intro. That's the intro to schema. And that was the second part of the question, Rebbie, if we have time.
You know what? I hate to say it. I wish we did, but
I think we're
I'm going to be staunch here. So it's about everyone, just FYI, about 3 minutes each. But that was, thank you, Robert. Okay, next up, Kangkana.
Hi. Just want to check is if my feedback is all right. All right. So yeah, I've been really thinking about how to answer this question within 2 to 3 minutes band. And I'll start with the second part of the question first as to like what got me here. And I think that will help kind of like summarize what DBT is. One, I thought that why DBT was because I thought I was emotionally dysregulated, which is not to say that I was suffering in the way that somebody with BPD diagnosis was suffering. It's just like to see that, well, emotions, why are there so many emotions, right? They're so overwhelming. They're constantly there. And I'm finding that a little bit hard to manage. And now coming to where I was at in my practice, which was the university setup, and we like largely, really, very specifically started working with clients in psychotherapy and started seeing this subset of people who would come with a lot of difficulties managing their interpersonal relationships. These are like really young crowd. Relationships tend to be like super important part of that life, just entering this transitional period in their life and, not doing too well with them and then having these really highly impulsive behaviors like cutting, drinking, and, a lot of those things. And, as a therapist at that point of time, getting there, like, and then I'm also seeing that, okay, they are coming up with so much heavy emotions, and what we are able to do is retain them, and we are able to maybe kind of see where they're coming from. But what we are not able to do is what are we doing to change the suffering for them? They would come with highly self-harming tendencies or suicidal behaviors, and because of the setup, there would be a lot of people who would get involved. Everybody would get anxious about their, safety. And so the forefront always then tends to be this self-harming behavior, right? And everybody's just kind of like getting very anxious about managing that. And I personally didn't think that, just the mechanism of CBT. I mean, because I thought that they were very rational, they were very insightful. They knew rational in the sense that they understood where the problem was coming from, but they just did not know how to like implement those changes. And it just happened to be that okay, I read like this book written by Marshall Linehan, and if I may, very quickly, I'm like sort of stealing her words here. And if I can just quickly quote something that really, really struck me and that led me to DBT was this. A dialectical perspective suggests that within dysfunction, there is also function, that within distortion, there is accuracy, and that within destruction, one can find construction. And I think that suddenly really kind of clicked. And that is where, like, coming to the first question, like, this is why DBT. And this is like a synthesis of technique of acceptance, which is like a lot of validation strategies, and technique of change, which is like, a lot of behavioral strategies, which are again divided into very specific core components, 4 core components, which is like emotional regulation, mindfulness, interpersonal effectiveness, and distress tolerance. So, this is DBT in a nutshell.
Thank you very much. I will say that quote that you just gave, I would say if you, I don't know if you tell the people who you treat, if you relay that quote, but it is very, it's a very hopeful, motivating statement. Okay, Ashlisha, go for it.
Thank you. Thank you. I was so fascinated to listen to everyone. I could listen to that for longer, but I also might start with, my journey a little bit. So I was training as a perinatal psychiatrist and doing psychotherapy training side by side. and I did work in a DBT team for a couple of years. Again, similar to what a lot of mental health professionals experience, we start seeing people with borderline personality disorder, and then feel that whatever we are doing is lacking. And so, when I was working in the DBT space, I also got introduced incidentally to Professor Bateman, who was visiting at that time. And I actually, to be honest, just went to the course because I had read his books, and I'm like, oh, Professor Bateman is coming, so I must go listen to him. It's only when I went and then immersed myself in trying to understand MBT, I realized it really aligned more with the other work that I was doing as well. So I was working with unwell mothers, and I was actually seeing the development of attachment trauma when mothers are unwell and unavailable, not because they intended to be so, not because they deliberately trying to harm the infant, but there is attachment trauma happening. And what MBT was telling us was that when there is attachment trauma of any kind, like if there is insecure attachment that might develop, or something is happening in the early years of person, that can result in difficulties in regulating motion, difficulties in being reflective, understanding self and understanding the other, and perhaps developing coping mechanisms that are not very helpful and healthy. So what MBT really looks at is, trying to understand someone from the foundation of attachment and security and the resulting dysfunctional coping mechanisms, which were functional at some point, result over time when they get used, even when trauma is not occurring, then become dysfunctional, and then they almost present in a way that does a disservice to them. So they start what we call as not mentalizing. And MBT is really mentalization based treatment. So, what we are doing in mentalization based treatment is recognizing what leads to this person not mentalizing. And it's not really trying to say that what everyone who's not mentalizing has borderline personality disorder, or people with borderline personality disorder are all non mentalizers, but they have a more propensity to not mentalize. All of us can lose our mentalizing. Like if we feel insecure, if we feel anxious, we are likely to lose our capacity to mentalize. But people with trauma history, attachment insecurity are likely for that to happen more often, and also they're going to find it hard to regain it to be able to function. And of course, everyone lies in a spectrum. Someone might be at a very severe end, someone might be at a highly functional end, and so what MBT does is help try and make this link between the developmental issues that could have led to non-mentalizing, and helps identify what are the non-mentalizing modes. And essentially there are several ways of looking at the non-mentalizing mode. Someone could be and one of the things that can happen in non-mentalizing is you could be very certain, you could jump to conclusions, you could sort of think that uh, you know if one person doesn't reply to your text message, you might think, I don't have any friends, no one loves me. And I'm simplifying it, but there are similar non-mentalizing modes. So it's helping to understand what are these non-mentalizing modes. But more importantly, through structured therapy, it's looking first at here and now. So the difference between what MBT did in terms of developmentally, it comes from more psychodynamic background as opposed to, like Rob was mentioning, CBT. Both I think DBT and Schema come from a CBT background, and MBT comes more from a psychodynamic background, but it shifts a little bit to start with the here and now first. So it's not going to straight away go into the trauma because there isn't enough core resilience in the person to be able to deal with it. So first it's dealing with the here and now. What's happening right now? What's leading to you losing your mentalizing? And it's giving that secure base and validation to allow the exploration and rebuilding of some of that mentalizing capacity. And when someone starts mentalizing, they're able to understand themselves a little bit more. They're able to understand the others a little bit more. So their capacity to reflect and balance between self and other, balance between their thoughts and emotions, balance between what's inside and invisible and what's explicit and outside. There are several poles that they learn to balance between. And then that robustness and the safety that they feel with the therapist helps them to start addressing the trauma. So this is essentially what we do in MBT. And I think similar to DBT and Schema, we also have group modality and individual therapy modality. And the group modality really helps in, learning and sort of reflecting with each other. So we try and teach them relational reflective capacity as well. So that's MBT in a nutshell, very quickly, but over to you, Rebbie.
Wow, thank you, Ash. That I've tasted all of them, so those are all extremely helpful descriptions, experientially, by the way. Okay, moving on. So I think you have done, all of you, a really good job of describing why those treatments resonate for treating personality disorders. We didn't go into depth as to why you chose them, but I think the description that you've all given indicates why you see them as so specifically effective in treating BPD. So, next question, or first official question, is what in your experience have you seen, or when have you seen these treatments, or where have you seen them falling short when you're treating people? And what do you do when that happens?
Do you want to?
All right, let me, Robert, let's start with Robert.
Okay.
When has schema
Look,
not met
I'm
the moment?
super biased. So about schema therapy. So take it in that context. Yeah, these disorders can be difficult to treat. Of course, that's a sort of characteristic part of it. The times that I have struggled would be when there are ongoing sort of systemic issues in the case. I think this is one of the biggest challenges. So I think a lot of these therapies, I can only really speak for schema, let's say, work best when it's a sort of almost a post-traumatic situation, that it's post-trauma in a lot of ways, that the childhood has happened, this person has become an adult, and they've gone on and starting to live their own life. Hopefully, often they have their own place. They're no longer living with their parents and those sort of environment. And that's sort of ideal, that they're not sort of still in it in a way, still being either abused or neglected or ignored or invalidated in ways that might still be so triggering for the case. I find when that's the case, then things are relatively smooth. Of course, it's not perfect, and for all the reasons we know. But in cases where there's ongoing stuff going on and they're sort of stuck living at home, and let's say they have parents who are really on top of them or abusing them and things, I've always found that a big challenge. Yeah,
that's fascinating. To know that it's really so much better to have it makes so much sense to have the person out of the environment, but as someone who had been treated for this, it's fascinating to hear some of the overt obstacles to treatment that a clinician considers. Kangkana.
If you're talking about DBT just as a model of treatment for BPD and exclusively just that, I think it works really, really well. It's very effective. Again, like Dr. Robert, as the way he is biased towards schema, and I'm like similarly feel biased towards DBT. One, because the expert of DBT herself, like she had this lived experience, Marsha Linehan. In 2011, she came out and spoke about her own personal experiences struggling with significantly self-harming behaviors. And it boggles my mind that at some point of time she was hospitalized for a little over 2 years, and that's like really difficult to imagine. And from that person to this person who has come up with this treatment model, which actually works pretty well. So if like coming back to that question, like just for BPD, I think it works really, really well. Now, as Dr. Robert himself was saying, there are of course systemic issues which kind of gets into the way, like financial struggles or maybe parents sort of not wanting to have these people come for therapy, or like, there could be something else also ongoing in their environment. So there is that. Having said that, if there is an other kind of comorbidities as well, and for me specifically, that challenges very specific trauma-related outcomes. For example, dissociation or freezing behavior or hypervigilance. And I think that like strategies in just DBT alone don't address that really well. Of course, there are other protocols and other forms of DBT. Like, one needs to get trained in before they move into addressing that. So yeah, if I'm talking about the comorbidities, and that's probably a challenge with just DBT.
Thank you. Ashley?
Yeah. So I think one of the difficulties with MBT is that it's and I think this is true for any therapy, that you really need to feel comfortable with that style, right? And it's not a very directive style. So it is a little bit more exploratory. And initially, when someone is looking for skills as such, so MBT will allow for the person with the personality disorder to use whatever skills they have, could suggest, skills that are derived from DBT or mindfulness or other modalities. But MBT itself doesn't define, this is how you will regulate your emotion. What, so I feel like sometimes in the initial phase, where someone is actively looking for skills from the therapist, I have found myself having to use other modalities to, address that gap. But it's not considered a gap in MBT. It's considered that, we are here, we are providing the safety. You allow for the patient as to take whatever they need from wherever they want to utilize the skill. So it's almost like when they develop the skill on their own, that's going to last more rather than you just giving them something. But definitely in India, where there is a clear looking at the therapist to give them direction. Sometimes that can then feel like, you have to do a lot of initial work that is not MBT to then start reaching a point of MBT. And it's now been built into it. So that's one thing that definitely I feel we derive from other therapies. Fortunately, the systemic thing is another thing that you're working individually with MBT. It may or may not get addressed, but because mentalization-based treatment has been expanded into so many other spheres, there are MBT for families, MBT for adolescents, and which includes cultural and systemic issues. So that seems to have been addressed. But I think in the original form, when it was only looking at individuals, that was also one of the drawbacks of MBT. But yeah, I think it's a style. It may not suit everyone. It's not very directive. It's more exploratory and psychodynamic in nature.
Thank you. That's interesting. I didn't actually know that MBT built into itself the opportunity to utilize different modalities when needed. But it sounds like that's what you're saying. Is that right? Get that right?
Well, that's what I'm doing.
Yeah, that's what you're doing. Okay. Well, we have these sort of two questions that I think we just sort of collapsed into one. So I'm going to pull in the question behind them, which leads to the three of you. What is your knowledge of other modalities? And are you ping-ponging use of those modalities when need be, and pulling in other skills, capacities, strategies when a client needs it? And I ask because I had the privilege of being treated at this in the Gunderson residence, which is extremely fortunate. And the treaters there were trained in DBT, were trained in mentalization. I think they're now somewhat trained in transference. They applied schema, they applied ACT. And so, and I found DBT useful for sort of understanding the architecture of BPD because of its four quadrants: mindfulness, mindfulness, distress tolerance comes first usually, affect regulation, and interpersonal effectiveness, which I think, anyway, so I asked that to each of you. Do you know different modalities, and do you apply them in a ping pong fashion? And if so, is there one example you could give of a time that you've had to do that? Robert.
Yeah, we're in a pattern now.
Mm.
So there's probably two things I'll try to quickly cover. I always try to also pay attention to the evidence as well. And in schema therapy, we do have a model, but it is very integrative as well. It's relatively easy to integrate other models as long as it makes sense under our case conceptualization. All right, and most of the time that's not too difficult. One example of that is, and this is also potentially a weakness of the model, because it's so past focused and it's focused on unmet childhood needs, and personality disorder is such a focus. Sometimes people's problems are wrapped up in more sort of, it could be either single incident adult trauma, for example, or just, PTSD, adult PTSD, single incident adult PTSD. And the model is not very well designed for that kind of problem. It's much better designed for more characterological problems and developmental trauma. So I have found myself using EMDR in particular to substitute the trauma processing technique in schema, which is so past focused, right? Which is imagery rescripting, usually with childhood memories related to childhood, with something that's very well equipped, but also evidence-based to deal with single incident adult trauma, which is EMDR. So that's one example. That's something that many schema people really like EMDR, and it's sort of seen as close cousins in a way. And the other one I've been involved in quite a lot is integrating ACT third wave techniques, compassion-focused techniques, into what we call the healthy adult mode. So there's one of the modes in schema therapy, we call it the healthy adult mode. And in the past, there has been a sort of lacking in instructions for how to develop that mode outside of the regular techniques, which is to do with the therapy relationship and treating trauma and things like that. There hasn't been a lot of explicit instructions on how do you build this mode explicitly. And I've personally found some of the, particularly the ACT techniques, I think DBT also does a good job of this, as some really good techniques to be able to explicitly build that mode. So myself and a couple of other guys, we wrote a book on this in 2018, and we called it Contextual Schema Therapy. So you could check that out if you're interested.
Fascinating. Thank you for detailing that. Kangkana.
So DBT itself has taken a lot of its core components from so many other modalities, right? Like it goes without saying that there is CBT. It goes without saying that there are behavioral principles which are being reinforced and taught here. I'm not sure people talk about it too much, but I think, again, people would be aware that it also takes a little bit of its working from attachment lens and psychodynamic principles, because it has conceptualized, the concept of transference and countertransference in terms of therapy interfering behaviors. So basically, what I'm trying to say is this, that I think in some way, even if we are being adherent to a particular form of therapy, we are sort of like taking things from here and there. And I think it would very much be a bit of a reflection of the therapists themselves, as what they have kind of looked up or really read up and really related to, and bringing it into the picture because they find that helpful. So I think that kind of boundaries are not very restrictive in that way. Similar to, again, Dr. Robert, as I was mentioning, the trauma part, right? So I feel like there is definitely a bridge. There's definitely a gap there which needs to be bridged. Although there are forms of DBT which works with trauma protocol. It just sounds intimidating in the way that they work because the protocol itself like kind of looks at really sitting with the trauma incident itself and working with the clients. And that way EMDR sounds like a really good bridge. It kind of like maybe doesn't destabilize the client, or hopefully would not destabilize the client as much. And just to like answer your question, that is something that I hope would be a magical combination.
Thank you for getting specific with that. I have more to say, but I won't say much. Go ahead, Ash, and then say what I think.
Thanks, Rebbie. I'd rather listen to you. But so in terms of, I mean, I guess I find that because I'm also a systemic therapist and a family therapist, it's working individually is quite limiting. So I started doing MBT group in India because I was one of the few ones, and I kept seeing people individually. It just didn't, I couldn't do justice. But when I started working with groups, it became very apparent that there was this whole family environment in the background, especially in India, and there were a lot of young people who might have been adults, but they were dependent on their family. So I felt like I had to do something a little bit outside of the clinical space for these people that I was seeing. And so we started doing just like a supportive family education for the family members of people who were in the MBT group. And we were just telling them about MBT, what is mentalization? What are we doing with your child or spouse? Without telling them what the children were telling us. I'm saying children, but these are 19, 20, 21-year-olds. So at that time, we were just doing sort of, giving them information and maybe giving them some skills based on our common sense. But since then, parallelly along in the MBT world as well, it's kind of now a evidence-based program that's developed, which is MBT Facts, which we are adapting now in India, which is like a group for family members of people with personality disorder. And it's not a therapy group at the moment. We are offering it as a education plus skill development group, but it really uses the information side of mentalization. And I find that complements, that work actually is complementing what we're doing, because when we work with borderline patients, one of the first things they tell us as they start getting better is like, you're teaching us how to mentalize. But there are people around us, like my mom who used to abuse me, still not mentalizing. My so and so who's around me is still not. So what do I do? And it's not so easy for them to disengage from them in India. So when the family members start coming and they start sort of either making changes or understanding their relative with personality disorder, then we really start seeing some systemic change, which I think is like not necessarily only doing MBT, but expanding it and adapting it into the system as well.
Can I
It's
just
so
jump in
interesting.
and make an interesting comment, maybe, Ashleisha? You remind me too, we often see that when our clients start acting in a healthier way, BPD clients especially, that other people start having symptoms. People.
Absolutely.
Yeah, sort of. Yeah, it's interesting.
Yeah. We see that all the time.
Yeah, years ago when I was in treatment for an eating disorder, but I remember they reminded us, when you start to get healthy, beware, because the people around you don't know how to respond to someone who's actually holding court, holding their own. And I do think one of the benefits of getting up capacitated in mentalizing, among all of the other modalities that sort of begin to rebuild one's ability to connect and to themselves and others, is that you really do begin to recognize deficits and vulnerabilities in other people. I think one of the benefits to that is, you have to make decisions. How much am I going to engage deeply in certain ways with this person, given their skills? What can I do to sort of maybe trigger mentalizing for them? Or and it's not always possible. And then there's grief and other experiences involved in tolerating what you can't have from someone, where maybe you're not going to engage in self-harming or other kinds of behaviors as a result of that disconnect. So a little bit or a lot has been mentioned regarding trauma in this conversation, and that personality disorders and BPD is really attachment, sort of a form of attachment trauma. However, and we get this a lot on the channel that I work on, people are always confusing or saying, is it CTPSD, complex post-traumatic stress disorder, versus just BPD that this person has? And I would like to hear how you all conceptualize the difference between when a patient is sitting in front of you who is sort of exclusively CPTSD, if there is such a divide that you make in your mind, versus BPD. And does it all, I guess the question is, does it all fall away when you look at it through a trauma-informed lens? My personal observation, just interfacing with people on our channel and people who reach out to us, is there is actually a very qualitative difference between people who have a CPTSD pathology versus people with a personality disorder pathology, in terms of my feeling of relating to them and how sort of stable the interaction is and how I feel when I leave it. Like, okay, the solidity of the person is still intact. And I kind of know where they stand, but maybe I'm wrong. So can you explain how you experience the difference between those pathologies when within a person?
So, I mean, I think you bring this up because it's obvious that there appears to be a lot of overlap. So that's what I guess where the question comes from. In the schema model, it's actually a very transdiagnostic model. So to some degree, the diagnosis in some ways doesn't really matter, even though it's going to tell us some information about, for example, how long treatment might go for, or it might sort of change the way we deliver the treatment. But diagnosis itself isn't super important to our conceptualization. Rather, we rely upon the idea of schemas and modes to sort of tell us about our case conceptualization. So I wouldn't say we're anti-diagnosis, but it's just not super important. Having said that, we've done a lot of we played the game of research and randomized control trials so that we can demonstrate efficacy. But regarding those two things, mostly I would see the differences in the kind of schemas that are more common between the two problems. So in the case of BPD, the schemas tend to be more to do with things like abandonment schemas. So it's a fear of other people leaving or a threat to your relationships, emotional deprivation, so sort of a core loneliness, and also defectiveness, which is a sort of a sense of being worthless and having an experience of invalidation. In complex trauma or CPTSD, the schemas tend to be less around the attachment stuff and sort of the need to belong and the need to be close to others. Rather, the core need that's front and center is safety. So we see those folks as at the core of it, they're afraid to be around other people. They have schemas along the lines of vulnerability to harm and mistrust abuse. At the core of it, they see the world as scary and dangerous and other people as abusive. And that's a core difference. Many BPD patients at the core, they want to connect. They yearn for connection and they want stability in their attachments. Folks with CPTSD in general see other people as scary and dangerous at the core. So that's probably some of the main ways I'll differentiate. And related to that issue, we see issues to do with core intrusive symptoms of PTSD as also front and center in the presentation. Yeah, where you don't necessarily see that in BPD.
Fascinating. Okay, Kangkana.
Yeah, before you call me out, I think I'll let Dr.
Oh,
Ashleisha take that
okay.
because I feel like both of them are going to answer that much better. And I think I may not necessarily have something to add to that, but I have a tangential point. So, yeah.
Okay, go for it.
Sure. I mean, I feel like Robert's explained it really well. The way I see it, and I guess it's um, people with personality disorder, or there is sort of an enduring fragility in the personality, right? And that's how we understand in MBT terms, or in any therapy terms. When you're trying to understand, the self-esteem is affected even before it is formed. So because the attachment insecurity and difficulty in making sense of self has an impact on the core personality, there is a little bit more fragility when you look at someone with BPD. But someone with complex PTSD, uh, I think originally it got started off by sort of recognizing that not everyone with trauma meets the criteria for personality disorder. They may have undergone a lot of trauma, but they seem to have some kind of core strength, and so they're probably better identified as a, whatever you're seeing now in them is a result or a sequel of multiple different kinds of trauma. So originally it got started off as a way to destigmatize, to understand people who didn't quite meet the criteria for borderline personality disorder. And now we know that many people present with it. So it's the way I understand it is that someone with complex PTSD has maybe similar experiences developmentally, but the way their personality has shaped up is slightly different from someone with personality BPD. And while their presentation, so there might be similar dysregulation, there might be similar non-mentalizing, there might be similar interpersonal difficulties, but there is some core strength in someone with complex PTSD. And sometimes we can also do is they can present more with immediate trauma responses. There is more sort of dissociation, maybe sometimes more flashbacks. So the trauma symptoms are a little bit more enhanced, especially when they go into crisis. And that's how I see the difference. But I feel Kankana, you definitely might have more to add. So it's up to you.
Oh, no,
I
no,
mean,
no.
Rebbie.
I was correct that both of you actually already answered the question really, really well, and I don't have anything valuable to add to that. But because it was framed as a trauma lens, and I think that is nonetheless still helpful. I'm trying to make a slightly different point. Maybe it applies a little bit more in context of India and the way, like, our cultural and societal framework is. And we have this wonderful system called the caste system in India, which obviously I'm joking, it's not the best. And like there are divisions of people based on that, which like provides them with certain kind of privileges and deprives other section of people completely of that privileges. Then add to that there are other layers, right? Like, financial accessibility. And then there are other layers like, sexual orientation or how heteronormative we are in our presentation, or like, so what, like the thing that happens when it comes to that is we also sometimes have a subset of people who come to us diagnosed as BPD, but what actually is happening is this, that they know who they are, like, but then they're getting persecuted for who they are. And so like somewhere their non-conformative way is seen as problematic. And so somehow, like, they seem dysregulated individuals, or, they don't seem to be getting well with, the rest of the people in this very ecosystem. And so they can then come to us. Then it seems like they don't necessarily need therapy for BPD. And in that case, I think the lens, what it helps is maybe like, this label can sometimes become a tool of oppression. And that's just what, I just wanted to tack on, like having this intersectional lens can also maybe be helpful.
Thank you. That's an interesting perspective on it? And just to clarify, you were saying having the label of BPD can, or were you saying the label of BPD can
So I would say
essentially
that,
be a problem?
yeah. So what I was saying is that, then here are these people who are not necessarily meeting the criteria of BPD, but because of the systemic issue, they're like, like they get like passed on to different mental health services, diagnosed as this, and that's when, that label is not really helpful. In fact, the very
Got it.
opposite then.
So essentially what you're saying is systemic problems can result in inappropriate label or pathologizing maybe reasonable problems.
Correct.
And then the label's getting used in sort of a derogatory way, or a way to sort of diminish the reality of the system that they're interfacing with that is causing the agita. Did I get that right?
Actually, you said that much better than I did.
Okay, no, so we have 8 minutes left. So I think you all touch on that, but that does lead to a question. I think dear to my heart, so important, which is, I'm going to read it out, but I'll expound ever so slightly, which is how to navigate the interpersonal and sociocultural aspects underlying, this is a big word, the lack of epistemic trust as conceptualized in MBT. But Kangkana, what you are talking about right there with regard to the caste system, which inevitably is a system that is not for many people, right? There's many people that inherently shouldn't trust a system that is built to diminish and disenfranchise them. And so when you have sort of an overarching system parent that is there to keep you down, it has an impact on one's ability to trust in relationships. If one of the primary relationships that's in charge of how you pay taxes, how you trust the healthcare system, like your daily interfacing is sort of not reliable because it's not out to support you. How you deal with that, we have it in America, as many people probably see today. It's coming to a head in a whole new way, but it's been here forever, and it has been a caste system in this country too. And so how do you address the reality of the cultural spaces that people come from when they sit in your office? Because that affects I'll give you one quick example. There was a woman I met years ago who was a Black woman, and she told me, when I go into stores, and she was just physically tall and not a tiny person. And she said, I go into stores and I get watched. And some person could say, oh, that's just hypervigilance and we got to work on that. But the reality in America is if you fit that physical profile and you're walking into many stores, racism may create the reality that she is relaying, which is very different than someone who looks like me saying, I get watched, potentially. Depending on how I'm managing myself in public space, if I'm looking suspicious or not, which anyway, so,
I mean, I'll have a crack. I think this is a big frontier in clinical practice. All of these models were developed in Western settings, and then we run around the countryside to different places and try to apply the models in places like Asia and other places, and it doesn't necessarily fit really well as you might have learned it in New York or in these kind of settings. So I think there's when we teach this is what I learned doing a lot of trainings over the last 10 years in places like Singapore and Hong Kong, that while I'll teach the model, there's another layer that folks have to go through. Once they learn the model, they have to go out into their communities and then figure out how to apply the model in their own communities. And, while someone like me could provide a little bit of guidance about how that might look, that's another piece of work. Unfortunately, I think for therapists that are from diverse communities and places other than, the standard Western psychotherapy settings. So, but I'm pleased to say, and I'm going to do a little like weird flex here. I am going to post in the chat a paper that we published a couple of years ago, because what we try to do is engage with the folks that did our training in some of these places, and to find out from them both the challenges in applying the model, particularly in this case, it was in Asia, in Asian cultural context, some of the challenges, but also some of the solutions they were finding, some of the cultural solutions, and they come up with some really interesting stuff. So I don't want to take up too much time, because I want to also hear from the ladies as well. But basically, go and read the paper. It's right there for what I'm thinking.
Okay, who wants to take a crack at this first? Kangkana? Ashlisha? Which one of you?
I think,
yeah, go for it,
yeah.
Ashlisha.
Yeah, I mean, definitely. Even when we started applying MBT, we straight away were looking at how do we adapt this culturally. How do we adapt the formulation of personality disorder itself in the cultural context? And I used to maybe assume naively, but also get told that, you don't have that much of personality disorder here. But I think when you strip it down to the basics, it's definitely there. It's about how can you include the cultural context. So the formulation, because MBT lends itself quite well to using a developmental model for the formulation, understanding the world of this person while they're developing. So it's not necessary if the parent was not traumatizing the child, or not just the parent, but the environment was not particularly traumatic by someone's standards. But if the person growing up felt invalidated, whatever their cultural context is, right? So I think it's to be mindful of the cultural context, but also almost irrespective of the cultural context, what is the experience of the person, and how did that lead to them feeling invalidated? So I think Kankana's example is quite a good one, where again, when we have conversations around caste and races, and even a lot of conversation around, say, people from LGBTQ communities, while someone might say, because I was growing up as a queer person, I felt ostracized. There are like 100 voices will say, oh, but you didn't have it that bad. And what are you complaining about? And, so I think that comparative of it's not bad enough for you, so you should not complain, is when the cultural sort of dysfunction arises. So what we look at is, irrespective of what may have actually happened, what was your experience, and then build from that. And then, so keep the culture in mind, but also the personal experience in the context of that culture is what we look at as well. And of course, in our systemic work, we are trying to bring the culture in. But I'm very interested in what Rob mentioned, in terms, and we're still in our nascent stages to start studying the adaptation. What are the challenges? We are definitely facing some challenges, but we are also facing the easy adaptability of MBT. So it'll be good to follow on Rob's paper maybe a decade from now, if we can.
If you guys have time, once we hear from Kangkana, I can tell you like a really brief thing that's kind of interesting about it. Kangkana?
No, I think I sort of like already made that point when I was talking about that, but please go ahead.
I actually have one thing I want to say as a patient, as a former patient, which I think is overlooked, which is just because you sit in a maybe sort of dominant culture position, though I don't know, I mean, I think women do and don't, and I think many systems are built on assumptions about marriage and sort of structures of relationships that are presumptive and not actually don't often serve women in general, and that therapies are based on even with certainly personality disorder, having attached relationships romantically, and that structure is a presumed safe structure for women. It's not. Statistically, it's not. But what I would say actually is that people even in dominant positions, by not carrying the lens of cultural sort of experiential awareness, it actually hurts them too, because it's not real. It's not dealing with the reality of the street. Certainly in New York City, I walk down every day, which doesn't look, it's so mixed. And so it doesn't help anybody, not just who it was built for, to stay within that framework, period. That's my sort of hard-won belief about that. But okay, go ahead, Robert.
Oh, all I was going to say is that one of the things that we found working with Asian cultural patients, which was a bit interesting for us, we have this technique which is imagery rescripting. So we're going back to childhood memories and we're revisiting them. And often that means interacting in imagery with people's parents. In general, I found in Western settings, we don't mind beating up the parents in a way, right? We don't mind blaming the parents, or we don't mind standing up to the parents and to sort of really put responsibility on the parents for certain unmet needs. On average, in Western culture, this is okay, for the patients. In fact, they really like it. This is a big violation in Asian cultural contexts. I learned the hard way. So this is something that on average is not very well tolerated. And so this is one of the adaptations that came out of the paper, is that you have to change the approach to the parents. It has to be a lot more respectful, a lot more compassionate, and more understanding if the patient is going to accept that sort of intervention. So I thought you might find that interesting.
That's amazing. That's fascinating. We are at time. So everybody, there's a number of comments and links in the chat that I direct you to before we end this, so if people can copy them. Robert put trainings for schema therapy as well as his paper. Shruti just shared feedback, correct, for this webinar. Anybody help me out how to end this?
Over to
Anything
Pavitra.
else we need before we end? Any closing? I mean, other than this was incredible. This was very informative for me. So thank you. It's fascinating to hear from people from so many different, from certainly not America. So I'm very grateful for being offered the opportunity to sit with you guys. But help me out here.
Absolutely. Thanks, Rebbie. And we were just getting warmed up, and I think there was some. And there's so many questions that are coming up in my mind that, but we wanted to keep this short because this was the start of a conversation. And one of the reasons why we thought we should bring this together is to look at complex cases and talk about how it's never one modality. And one of the things that the PARC does is to say that you need multiple skills. You need to sort of follow. One is how you practice as a therapist, and also look at how your clients or your patients are responding to you. And we certainly don't believe that, one size fits all. And so we thought, why don't we have a conversation with multiple modalities? And we've done this before with for a number of other complex cases. And this was so rich. And I'm hoping that the takeaway is to sort of expand skilling, expand how you think about managing and treatment. And definitely keep the conversation going. I'll urge everyone to write to us if you want to connect with Robert or Kangkana or Rebbie, and of course us, for anything, for the wonderful work that they do. We'll be happy to pass you on to understand training pathways, to understand what they do. So we're super excited to be the conduit. The PARC, of course, offers the MBT training. We have one coming up in June with Professor Bateman himself. Both the basic and advanced. But if you want to reach the others for training programs, we'll be happy to make the connect for you. We hope to continue this conversation. And Rebbie, thank you for making this so very rich, and it was fantastic. Thank you so much.
Thank you all.
Thank you. Really honored to be sharing this platform with all of you. Yeah. Could go on for a while listening to everyone. So hoping to do more of this with all of you.
Thank you.
Yeah. Thanks everyone.
Thank you guys. Thanks, Rob. Thanks, Kangkana.
Of course. Thank you all.
Bye-bye.